Hello, welcome to This Week in Medicine. It's January 24th, 2022. Thank you for joining us. At the Fox Health Foundation, we have an education mission, part of which are our weekly This Week in Medicine updates. We also do lectures, educational sessions, and we will be either virtual or hopefully in person at the American College of Cardiology meetings in April. We have some foundation initiatives, including our book that was published. We have our wellness center. We have In-Balance Nutrition with Carrie, which is going well. And we will be expanding some of our classes at the wellness center soon. So in the inbox this week, we still have questions about Omicron and treatment, although I think many of you who've gone through an Omicron illness know that Tylenol, Chloraseptic, Mucinex, and Flonase are your best friends. That seems to be effective in minimizing a lot of the symptoms. So far, I've done 2 sotrovimab orders for people who are high risk for severe illness, and that's really the indication for treatment with Paxlovid or sotrovimab. There's a pretty clear decision tree analysis process that goes into deciding who will get these prescription therapies as an outpatient. Inpatient treatment is, of course, entirely different, and thankfully, I have not had to refer anybody for admission recently and have had no admitted patients with Omicron. Still, there's some question about the antigen testing versus PCR test. I actually don't think I've put in an order for the PCR test in weeks. They're really not so useful anymore. The antigen tests are much more helpful. You can use these antigen tests to clear yourself early from Omicron infection. So if you want to leave your house still wearing an N95 mask from day 6, 7, 8, 9, 10, you can do that according to the recommendations if you have 2 negative antigen tests, day 6, 7, 8, 9, or 10 of your Omicron infection. Omicron does not seem to be affecting the scheduling of elective surgery, except for the fact that hospital staff were out, but otherwise my patients are getting their procedures. Finally, my inbox has been accumulating and often does questions about blood pressure. So we're going to talk about that today and leave some of these other Omicron issues to the end. Remember, you can order your antigen test kits from the United States government. Just go to this website. So far, I haven't heard that it's crashed. It seems to be running pretty well. I put my order in, haven't received it yet, but I'll let you know when I do. So what is high blood pressure? Standards for it clearly changed. The last recommendations were made a couple of years ago from the American College of Cardiology and the American Heart Association. It really should be individualized. These recommendations are population-based recommendations, but I'm not treating a population in my office. I'm treating you. You and your doctor decide what blood pressure is correct for you. It's also physiologic. Your blood pressure changes throughout the day. As I've told many of you, I don't want you measuring your blood pressure at 7 o'clock in the morning because that's physiologically meaning how your body functions the highest. So don't check your blood pressure at 7 a.m. Most people also who are taking blood pressure medication might be taking their blood pressure medicine in the morning. So that means you're having an end of dose effect. You're on the 23rd or 24th hour of the pill that you took yesterday for your blood pressure. So if that pill is ending its effect at 6 or 7 a.m., you shouldn't be taking your blood pressure then, because that's not a true evaluation of the efficacy of your medicine. We also have some new ideas regarding older people, people over 65. The standards for blood pressure and numbers for blood pressure clearly should not be the same for this population because they have a lot of arterial stiffening. The arteries get stiff over 65. They shouldn't be stiff when you're in your 40s and 50s, so the recommendations are different. At our practice in Fox Health Medicine, we are in a unique position demographically. We have very low hospitalization rates for our practice, so we really don't have many patients at all, thankfully, who get admitted through the emergency room or for critical illness. It's actually pretty rare for our practice to have anyone in the hospital. Right now, I think we have 1 patient. Also, our patients are drawn from Montgomery and Fairfax counties. They're the oldest patients in the nation. Our life expectancy in Fairfax and Montgomery County is definitely 90. So we have a unique position to be able to assess blood pressure because we do have a large number of over 65 patients, and we have to be careful not to overtreat an older person's blood pressure because it can make them lightheaded and dizzy, and we see that all the time. Why do we care about our blood pressure? What do those numbers mean? They are just numbers. Again, they have to be individualized and contextualized for your overall health. There's stress on the arteries that go to the heart, the kidneys, and the brain, and we'll look at that in a minute. Why call your doctor? Well, you should call us in case this is a new number for you. It's not a number you've seen at your annual physical. Maybe it's a new blood pressure cuff that a doctor has used on you, or you went to a new doctor, like a gynecologist who took your blood pressure with a machine, not a manual cuff. So that's why you should tell us. Should you run to the emergency room? Typically these days, not. People used to be concerned about high blood pressure as a sign of a need to go to the emergency room. But we're taking blood pressures a lot more frequently now, and we're more attentive to blood pressure. So typically you don't need to go to the emergency room because you've probably been in our office in the past year, and we've already talked about your blood pressure. What's a hypertensive emergency? That means a blood pressure that's so high that it's damaging one of these things, the heart, the kidneys, the brain. It means that the pressure is so high that it's damaging your kidneys and your protein in your urine. It's so high that it burst a blood vessel in your brain. It's so high that it is causing you to go into heart failure. That's what we mean by hypertensive emergency. So your blood pressure won't be just high in a hypertensive emergency, making you go to the emergency room. You may have heart failure, so you may be short of breath. You may be having protein in your urine. That's an emergency for your kidneys. And for your brain, it's going to be a stroke. So we don't see these very often because, again, most of you have been in the office in the past year. You shouldn't have a hypertensive emergency. Hypertensive emergencies tend to happen to people who have not been getting regular medical care. And as I told you, we have low hospitalization rates. We have very healthy people. So this is not a common occurrence for our patient population at all. So where does this pressure go? Well, these arteries in red are going to your major organs. So here you see an artery going to the kidney. If the blood pressure is high, it affects your kidney. This is your aorta. I had to draw in the blood vessels on the heart. These are your coronary arteries. These are the arteries where you would have a heart attack if you have a blockage of blood flow and a blood clot. But these are also the arteries that give blood to your heart muscle. So this is where you would have a heart attack, and you can see they're pretty small. Look how big your aorta is. It's pretty wide. But these blood vessels on the surface of your heart are small caliber blood vessels. If you have high pressure in those vessels, they're very small and very fragile. They really feel the sheer stress of that blood pressure. Another place the blood vessels go from the arch of the aorta, you have carotid arteries that go up your neck. I had to draw in the brain on this picture. So you can see these blood vessels go to your brain. So if you have high pressure in these vessels, the little tiny blood vessels in your brain feel that pressure as well. So those are really the most important organs, the brain, the heart, and the kidneys. Does high blood pressure affect the liver? Not so much. Does high blood pressure in these arteries affect the lungs? Not so much. There are intrinsic diseases, meaning diseases in the lung that lead to high blood pressure, but it's not the same thing as the high blood pressure you have when we measure it in your arm. Does your arm feel the damage of high blood pressure? Not really. Does your pancreas, which would sit about here, feel high blood pressure? Not really. So the main organs, again, are really your kidneys, your heart, and your brain. So again, not liver, not lungs, not your spleen, not your muscles. That's why our blood pressure specialists are cardiologists, nephrologists, which are kidney specialists, and neurologists, brain specialists. So these are the doctors, probably in order, whom you should consult for your blood pressure. So usually we would start with a cardiologist if you have complicated blood pressure. So when do you need to see a cardiologist? Well, the recommendations from the American College of Cardiology tell us that it's actually kind of complicated, and this is from 2020, in older adults. Why do we have to go beyond the 2017 recommendations for blood pressure measurement? Because older adults, those over 65, sometimes over 50, have more complicated blood pressure assessments and more complicated meaning for the rest of the body. Orthostasis is when your blood pressure drops when you stand up. It's interesting. This seems to happen at both ends of the age spectrum. It happens to some very old people, and it happens to young kids as well, teenagers. This means you stand up, your blood pressure drops, and it stays down and doesn't go back up. That can make you lightheaded. So that's a typical lightheaded symptom. That does have to do with blood pressure and blood pressure control. Frequently, patients can be on blood pressure medication that exacerbate this blood pressure drop when you stand up. You can be dehydrated, which exacerbates it, or you can just have aging effect on your blood vessels that makes your blood pressure fall. It's a tough condition to treat because if your blood pressure falls, but you also have high blood pressure, we still have to treat your blood pressure, but we have to minimize the amount of blood pressure falling when you stand up. So you'll notice that a lot of us will tell you, a lot of the doctors will tell you that when you stand up, do it slowly so that you can avoid that head rush. Atrial fibrillation also complicates blood pressure as you get older. Atrial fibrillation is an irregular heartbeat. It increases your risk for stroke, and it is exceedingly common when you're over 50. That can complicate treating blood pressure, and blood pressure has a different meaning in people with atrial fibrillation. And for that, you probably do need to talk to a cardiologist. We used to think atrial fibrillation was something that didn't necessarily require a cardiologist. If you're in atrial fibrillation, you just acknowledge it and move on, put somebody on a baby aspirin, but it's become much more sophisticated in the past 20 years because we can prevent strokes better, we can prevent heart failure better, we can do more with atrial fibrillation than we could do 20 years ago. So in my mind, if a patient has atrial fibrillation, they should always, at some point, consult with a cardiologist. This is not something an internal medicine doctor should be doing on their own. Also, heart attack complicates blood pressure. Because if you've had a heart attack, you need to be on a beta blocker. A beta blocker is a blood pressure medication. If you're not on a beta blocker with a history of heart attack, again, you should see a cardiologist. You might have heard this word this week from Dr. Walensky. She was kind of famous, I think, for saying this, comorbidities. What are comorbidities? It's kind of not a great word for lay people. We use it all the time in medicine. Basically, it just means other medical problems. So your comorbidities could be high blood pressure with diabetes, or high blood pressure with atrial fibrillation, or high blood pressure with a heart attack. So those are the comorbidities, the other medical problems that change how we interpret blood pressure. Also, you've seen before our pipe that we show that has plaque in it. How much plaque you have in your arteries definitely dictates how we treat your blood pressure, because some people with a lot of plaque are not going to do well with spikes in blood pressure. At the same time, if there's a lot of obstructive plaque in your arteries, if your blood pressure is too low, you're not going to get blood to your kidneys, you're not going to get blood through those arteries that are on your heart, and you're not going to get blood to your brain. So plaque burden also has something to do with it. So you can see blood pressure is not straightforward, especially if you're over 50. If you have any of these issues or you're at risk for any of these issues, you're going to need a cardiologist. And thankfully, I have the best one in town in my office. The benefits to treating high blood pressure with medication are many. The medications don't just treat your blood pressure. They keep your blood vessel lining young by preventing plaque development. Some of these drugs may also prevent diabetes. They may prevent heart attack on their own. And they also prevent the aging of your blood vessels. I know a lot of patients say, I don't like pills. They tell me I don't want to take pills. But honestly, with blood pressure, it's a missed opportunity to stay healthy. You prevent disease and you prevent aging with blood pressure medication. There's no research that documents that lifestyle and diet are better than medication for preventing aging disease of your blood vessels, your heart, your brain. Really, pills are superior. So I know that many of you are encouraged to try diet and lifestyle change, and we do encourage that, but it goes hand in hand with medication because medication has made a huge difference in cardiovascular disease deaths and endpoints in the past 20 years in particular, such that by now, without COVID, cancer was supposed to take over as the number one leading cause of death, not cardiovascular disease. And a lot of that has to do with changes in medication. The home cuff versus the office cuff, please don't use the wrist cuffs. The wrist cuffs are pretty inaccurate, so I just would not even buy a wrist cuff. Especially in people over 65, this is not going to be an accurate measurement of your blood pressure. The arm cuffs that you buy at home may miss this concept of arterial stiffness in people over 65. That's a natural aging of your blood vessels. They lose their elasticity, so they don't stretch. Sorry about that. So if your blood vessels aren't stretching anymore, your blood pressure goes up. Just today, I had someone bring in their home blood pressure cuff, and it was 20 points higher than what I got in the office, and that's pretty typical. We do have to calibrate your home blood pressure cuff. Also, dynamic blood pressure is best assessed with a stress test. That means you get on the treadmill and you walk. We want to see how your blood pressure increases with exercise because, again, if you remember when I talked about physiology, that's normal physiology. An echocardiogram or an ultrasound of your heart is an assessment of do you have high blood pressure changes in your heart. And that does dictate therapy because if you do, there may be specific medications that are better for your blood pressure once we make these measurements on your heart. If your heart already looks like it's dilating, which is something that happens in atrial fibrillation, we're going to want to decrease the dilation of your heart with diuretics. We want to get the extra water out of your heart so your heart stops stretching. That's just one example. But there's a lot of useful information on an echocardiogram for treating your high blood pressure. The appropriate use of a home cuff is a launch pad to an office assessment. So really we make the treatment decisions not based so much on your home cuff, but what we're finding in the office in correlation with your home blood pressure cuff. So it really does require an office assessment, particularly because we need to know these cardiovascular and kidney issues. The home assessment misses that organ damage that you might have. The heart on the echocardiogram, the kidney by checking a urine sample for protein or kidney number, and then also the blood vessels. We can look at your blood vessels with that carotid ultrasound. So it's really just a number isolated in time when you tell us what your blood pressure is. It's 1 minute during your 24-hour day. We need more measurements of what this number means because, again, it's a number. Again, DC and Maryland are not leading in COVID, Omicron, thankfully. We have peaked. Maryland is back to 50th in the United States for number of cases per 100,000 people for 7 days. So we're back at the bottom again. Congratulations. And Virginia and DC rounding out the bottom as well. So we're in waiting mode now with COVID. We'll have to see what's going to happen next. We have a little breather, hopefully. Hopefully it'll be a big one. For the practical guide to testing, I'll review this quickly. If you're sick, you can test immediately, but do it with an antigen test. If the antigen test is negative, but you are symptomatic, you could either get another antigen test the next day, or you could do the PCR test because the PCR test is more sensitive and will pick up the RNA from the virus. Once you're positive on that antigen test, don't keep testing. You may want to hold on to those antigen tests if you have any extra to see when you are negative. If you want to prove that you're not contagious again, try to get 2 consecutive days of negative antigen tests. If you're negative on day 7 and 8, it doesn't mean take off your N95 mask. It just means you can leave the house with it. It means you can leave your bedroom with it. And then up to day 10 is what we've been telling people, although I do have some people who may still have a positive antigen test on day 11. When do you use the PCR test? If you don't have time to wait till the next day for the antigen test and you're highly suspicious and you have a meeting that you're supposed to attend or you have a surgery that you need to get done, so for preoperative clearance, don't use it to prove that you're free of disease because remember, this test can be positive for 2 months, picking up random bits of RNA that are no longer contagious. Here are some of the Omicron tests. Antigen tests are the best thing to use, I think. I'm not really using PCR tests anymore because the antigen tests are pretty useful. And quite frankly, given the rates of Omicron infection and how contagious it is, if you have a sore throat, fever, body aches, a cough, you probably have Omicron. Again, the symptoms of Omicron, sore throat, it's a bronchitis, not a pneumonia. I haven't seen any pneumonia yet. I imagine it does exist, but I haven't seen it. Terrible night sweats, and those night sweats have been lasting people weeks. Fever, body aches, and yeah, I hear more about the diarrhea with this illness. Remember your masks. They're very effective if they're N95 or KN95, and I'm very happy to see the adoption of these better masks, which we have all been wearing since March of 2020, because masks are science, not politics. You can still get your test kits at the libraries, so I encourage you to check out your libraries for test kits, or again, order them. For outpatient therapy, Regeneron doesn't work. It was halted today by the U.S. government. It just doesn't work against Omicron. Sotrovimab does work. I can access it. I put through 2 applications for sotrovimab. We have it limited use for people who are at risk for getting severe disease. Evusheld just started getting distributed this week. This is for people who have severe immunocompromise, people who actually got no antibody result at all from 3 or even 4 vaccine shots. So it looks like we're giving that to people, hopefully this week, who have no functional immune system protection against COVID. We're hoping that Evusheld might give them some. Paxlovid's approved. There was an excellent Johns Hopkins medical grand rounds last week with a review on outpatient chemotherapeutics for Omicron by Dr. Weld. It was excellent. The points on Paxlovid are you do need to use reduced dose in kidney function. If people have severe kidney dysfunction, less than 30%, they shouldn't even be getting Paxlovid. So if you're about to go on dialysis, don't take Paxlovid. If you have reduced kidney function and you know your kidneys aren't great, which is not uncommon for people over 65, you need to take it once a day instead of twice a day. Also, your statin medication should be stopped. There are also some topical chemotherapy medications from dermatologists that should be stopped. The remdesivir pill is coming soon. So right now, remdesivir is an inpatient intravenous treatment. It'll be coming out as a pill soon. All this progress is really fast. If you consider that we only have 2 outpatient drugs for influenza that are functional, Tamiflu and Xofluza is pretty new. And influenza's been around, obviously, for a long time, and we have 2 drugs for it. We already have maybe 3 drugs, outpatient treatment, and it's only been 2 years. So this is really dramatic and remarkable pharmaceutical therapy. A 4th shot, no. Again, the 4th shot is for people who had never had a reaction to the first 3 shots, which means their immune systems are so weak they could not mount an antibody response, so not for most people. And remember, this was way back in December when we first started experiencing Omicron. Did Omicron get rid of the deadly Delta virus? Let's hope it did. We'll see what happens in the next 4 to 6 weeks if Delta comes back. Again, wear your mask. It works. It's protecting us. Tony's tip of the week: if you are in an emergency room or hospital, do not depend on us telling you that you are there or that you were there. They just don't have the staffing to do it. So ask a family member to call the office and say, Aunt Mary was in the hospital at such and such. Did you know she was there? Chances are we don't. Records typically will not be sent even though you authorize it. It's really just an authorization. So call us to let us know. Primary care doctors do retain a privilege, maybe a right to choose your specialist, and I do like to do that. So depending on what hospital you were in, if you broke your hip and you need an orthopedist to do it, it is my privilege to be able to recommend that to you at the hospital. But of course, I need to know you're there. Short-term stays shouldn't dictate long-term care. So if you're in the hospital and you're not sure if you should start a medication or if your outpatient therapy should be continued, definitely let me know because I can participate in those decisions. But again, I need to know you're actually in the hospital to do that. Fast pitch, remember, blood pressure is a number. It requires context. We need to know what that means for each individual patient. And if you're over 50, it's going to require an assessment of your cardiovascular system. Revisit your mask habits indoors. We still have Omicron lingering. It's not too late to get your flu shot. We give them all the way through March. Vaccination does not prevent Omicron transmission. It certainly prevents hospitalization and death. And remember, if you want to get some COVID tests, I registered for mine last week. I don't have them yet, but I expect them soon. Go to covidtest.gov. There are a couple of other websites too. Keep your pyramid functional. Make sure you've taken care of all of these things and try to set up your physical now because we are booking very late into the year because of the backlog from COVID. Remember, we still have our book available, which is a great thing to share with friends and family to make sure they are on top of prevention of stroke. Thank you for your attention and have a good week.